Welcome to The People's View, a program dedicated to discussing local, state, and national issues and their effect on the American people. The People's View provides a platform for state representatives and national figures to present their viewpoint. Whether it's social, economic, or financial topics, you'll hear it on The People's View.
Hello, I'm Carl Seidel, and this is The People's View. The People's View is sponsored by the Nashua Republican City Committee, and if you want to find out more about our operation and what meetings we have and speakers we have, just go to nashuagop.org. Today, we're going to be talking to Charlie Arlinghaus. Charlie from the Political Center in
the Josiah Bartlett Center.
Josiah Bartlett Center. Charlie, tell us about your involvement, I guess, in a way, of the meetings that went on last week on expansion of Medicaid with the federal money, and what you thought of the process last Thursday.
Well, it's been very interesting. I was involved over the course of the summer, from the beginning of July to the middle of October, in a commission. As part of the budget last year, they appointed a commission, and I was one of the 9 members. The commission included a majority that was going to recommend, well, in fact, what they recommended was essentially what was presented to us the first day. And I was in the other group that was a little more skeptical of it. It was an interesting commission in that we, early in the process, they didn't want us to ask too many questions. There were some limits on the number of speakers we could have. The last 3 or 4 weeks was much better with some degree of discussion, but like I say, the commission majority essentially adopted the plan that was presented to us by the Governor's Department of Health and Human Services on day 1. Coming forward, though, what that meant is that that commission was an interesting activity, but that its product was not going to be adopted. When the governor called for a 2-week special session, that recommendation was one of the recommendations. The Senate developed its own plan, and they tried to come to some sort of agreement in the middle. There were negotiations apparently behind the scenes for almost a month to try to come up with a plan. They didn't reach a plan. And I think they didn't reach a plan because, because there's disagreement about what's acceptable and what's not acceptable. And some of that has to do with the nature of the change that's proposed to Medicaid. I think that if you look at it, a lot of people think of Medicare as health care for senior citizens, which it is, and Medicaid as health care for people with low incomes, which it isn't. Medicaid today is a program where you have to have an income below a certain level and a specific condition or quality. It is a program based not on income eligibility, but on categorical eligibility. People in certain categories.
I don't think people really realize that point.
I think it's unusual, and because, like I say, people think, oh, it's health insurance for poor people, and it's you have to be, for example, disabled, certain categories of the elderly, people with developmental disabilities. There are certain groups there are pregnant women, for example, people with breast and cervical cancer. In the largest category, 60% of all Medicaid cases in New Hampshire are children. And there are different income levels for each of those. For example, some of the disabled categories, you can make up to 450% of the federal poverty level. It's a small group of people. Children, the largest category, you can make up to 300%. In this categorical eligibility, there is a group that's left out, and that is childless adults. In fact, most of our social welfare programs leave out childless adults. Some people call them able-bodied single people, which gives you an idea of their perspective on what should happen. Well, the notion of Obamacare is to cover this group of people from 0, which is where we are today, up to about 133% of the federal poverty level. We currently have 135,000 people in New Hampshire, about 10% of our state, in Medicaid. On average, it goes up and down each month, but on average, about 135,000. This would take that and make an additional 100,000 people eligible. We suspect that somewhere between 40 to 60 or 70,000 people would join up. But so what it would do is take a huge number, would take the number we have and take it from about 10% of the population to 15%. And I think that's where some of the dispute starts to come in. How do you cover this population? If we're going to add people to this population, are there people who should then be covered in a different way through a different program? What sort of exclusions and what sort of reforms might enter into the system?
They had two. You said they have two proposals, and from what I read in the paper, it seemed to me that the basic difference was that they were just going to do everything in the Medicaid. This was the Democratic proposal. In the Medicaid, I guess, what would you call it?
In the program, the traditional
programs,
program.
The traditional program, where the state pays 50% and federal government pays 50%. And they were saying that they were going to be giving 100% to this new category.
The federal government,
but they wouldn't guarantee it more than 3 years or something.
As part of the federal health care law, the Obamacare law, the federal government has said we will cover the new category and only the new category at 100% for 3 years, and then it will slowly ratchet down to about 90%, I think, in year 7. And then, in theory, it would be 90% forever. Some people are skeptical that the federal government won't ratchet it down a little bit more beyond that. But that's why this is happening now. In fact, this population, no one has proposed. I went back through legislation for the last 10 years. And people who think it's a great idea now never propose doing it. It's not like this has always been debated and we never quite got there. Even the most left-wing senators and representatives didn't propose covering this population because of the expense of it. But because the federal money is there, there's a move toward it.
Federal
That's
money,
typical.
that can lead you down a dangerous path, too.
It can.
And the Republican perspective was that they were going to take this money and not put it into the Medicaid pot, but to buy insurance through Obamacare or the ACA.
Yeah, so I've referred to the two programs as, and your viewers should know that I've been skeptical of the whole program. And I referred to the two proposals as Tweedledum and Tweedledee. And there are differences that the proponents regard as very important, and they ended up killing a deal. But each group, the Democrats and the Senate Republicans, would cover the same group of people. This 100,000 people who are largely childless adults with some parents. They would cover that same 100,000 people. They would use the same federal money to cover them. The Senate proposal, each of them takes people, so about 40% or so of this population currently has access to private employer-sponsored insurance. Both proposals would say, if you have that, you have to take it, and we will pay for wraparound coverage to pay your deductibles and your copays and your coinsurance. And we'll cover you that way. That way we keep you on private insurance. Now, why does anybody care about private insurance? Well, because private insurance will pay a provider 3 times what Medicaid pays. Medicaid is not health insurance for people in categories. Medicaid is a nominal payment that doesn't come close to covering the cost. Where the cost is, I don't know. Providers will tell you it's here, and maybe it's a little higher, maybe it's a little lower. But in fact, we pay about half of what it really costs. And private insurance will pay 3 times that. So if you are a provider and you have too many Medicaid patients, you go out of business because you just can't afford to stay in business. They need people with private insurance to pay more than the cost so that they can take the nominal but much less than the cost payment. It's like if you went into a grocery store and they're selling about 10% of the people cornflakes for $1, but you and I are paying $3. Well, they can only afford the $1 because it's costing them $2 to put it on the shelf because you and I are paying $3. So that's the way Medicaid is. The Democratic proposal would take the rest of the people who don't have employer insurance and give them Medicaid coverage. Well, Medicaid coverage has transformed. In the last legislative session, they transformed Medicaid into a program where rather than the state being the insurer, where the state writes the checks to the companies, the state has contracted with 3 private companies, private insurance companies, and you, if you're a Medicaid patient, you have your choice of any of the 3. And we pay a capitated rate, We pay a dollar amount as if it's insurance to that insurance company. Then they provide your insurance. And if you use a little bit more, they lose money. If you use a little bit less, they gain money. And so the incentive is on them. The Democrats would cover them that way. The Republicans said, let's cover these people through private companies. Well, we sort of are already. So it's similar. In fact, in the first year, their program was identical, absolutely identical. And then they would ask the federal government for permission to cover them a different way. It's important to know that Medicaid is not a program where we get to do what we want. Mm-hmm. We must play Mother May I with the federal government. We can only do what the federal government says we can do. And any change, however big or small, you need what's called a waiver. You go to the federal government and say, can we change the way we do this? Every state operates under a lot of waivers for little tiny things. Mm-hmm. Very few states operate under big waivers. We would need a big waiver. The federal government generally only grants a big waiver if they like what you're doing. Well, they wouldn't like what we were doing, so expansion is the carrot to get them to do that. I think the similarities are strong because the Republican proposal would say we want private companies to provide the coverage. Well, we're hiring private companies now. In fact, the private companies the Republicans would like to provide the coverage and to be enticed into the Obamacare exchange are the companies that are currently providing Medicaid. So what they want to do is have the same companies provide coverage to the same people, but with a slightly different plan. And it seems to me that it's remarkably similar. Under both programs, the number of people on Medicaid or quasi-Medicaid will go from about 135,000 to about 200,000 people. I worry about that creating a culture of dependency, and I worry about the cost. Mm-hmm. We don't really know what the cost is going to be. In fact, during the commission hearings, when Representative Kirk and I, one of the other members of the commission, suggested that we look into proposing some sort of spending cap. If we reach a certain number, enrollment gets capped until we get down below that. Yeah. They said you can't base budgeting numbers on the numbers that we're using for our budget because we're really guessing. We have no experience with this population. And so this is an educated guess, but it's not very accurate, and you can't make accurate judgments. Well, if you can't use the numbers for budgeting, then I think we have reason that we might want some sort of fiscal certainty, and there was none in either bill, so I was sort of opposed to both.
Well, I read your article in the Union Leader. It was very good on that point. But what actually broke down that caused them never to come together?
Well, at the end of the day, the governor and her allies, which consists largely of the House Democrats, don't want private companies providing this. Although that's currently happening in Medicaid, it's only sort of happening. And they worry about too many of these people moving into an exchange and moving as part of the exchange, even though we would have to provide wraparound coverage. Right. We would have to give them benefits substantially greater than are on the exchange. They worry about the principle of using a private company to provide coverage, even though that principle has already been breached in Medicaid as we have it today. The second thing they worry about is the timetable. Technically, the Senate proposal says that if the federal government doesn't approve every change we ask for, and therefore we can't switch programs, the program terminates, it goes away. And everybody who we've started providing coverage to loses it. And the Democrats in the House don't like that. Now, to me, I don't know that it's a real question. The truth is that once you give a benefit to 50,000 people, it will be politically impossible to take it away.
Right. Well, I understood that was a problem with a lot of people, a lot of the more conservative people, that once you're in the door, you can't get them out. And they didn't want to. They didn't want to get in there without.
We would be expanding forever and increasing the number of people on a benefit like this to about 200,000 without significant changes to the system. I think, by the way, so there are a bunch of different groups of people. Some people would just say, no, let's stick with Medicaid as we have it today. Others would say, all right, I understand you're trying to provide coverage to this people, to this group of this population. Let's try to find something else we could do. I think there are things we could do where we could say, all right, we currently provide health insurance to 135,000 people at varying levels of income. let's still provide coverage to about 135,000 people, but target it so that the people you want to cover, this is what I would say to the governor, so that the people you want to cover are being covered, but that we, at the upper income levels, so for example, kids are up to 300% of the federal poverty level. What about at 200 or 250%, if they receive coverage the way other people in that income bracket do too, and the way their parents will, through the exchange? There are some subsidized plans. Right now there's only one provider, so that we are providing coverage to the same number of people, but targeting it to the neediest. I think that would make some sense.
And that would cover the people, some would have a private insurance plan and some would have the Medicaid format.
I also think that to as great an extent as possible, you should, one of the things I did like about the Senate plan as opposed to the House is that this new coverage would be provided through the health insurance exchange. So it would create a new population in the exchange, and it would create a better dynamic to try to entice providers in. The exchange is kind of a nightmare right now, and something needs to be done or it's going to collapse.
What about opening it to insurance companies outside the state that don't have offices in the state?
I would open it to anybody. I mean, if we're going to provide a benefit, I would offer that benefit to any willing provider. I am focused on the problems with the exchange, though, because right now, there are such big problems with it. Only Anthem is in it, and Anthem is in right now with a temporary plan. They have, with most providers, they have a 1-year contract to see how it works.
Is that real? Oh, I didn't realize that.
And everybody else is staying out because they're skeptical about it right now because they don't know if they can make money. The other problem with Anthem's plan is that it covers about half the hospitals that are in and half the hospitals are out. I think it's actually 16 and 10.
Yeah.
Because they added a couple little ones in. But it's a problem. I mean, people are getting insurance coverage canceled and being directed to go there to a much more expensive and less and a less plan with less coverage.
And that those exchanges too, it's not. I guess you don't get the full amount of information from the insurance company, do you?
Well, I mean, we're really at the beginning of the process right now, and the setup of it has been a disaster with the websites, and they don't even work. But here's one thing we do know: 20 to 25,000 people in the state have had their plans canceled. They're no longer eligible. It's no longer appropriate under the Obamacare law for them to have it. So this happened to a friend of mine. He gets a letter from his insurance company. They say you no longer have coverage. However, you have to buy your coverage through the exchange. Here's a plan that's similar. He has a high deductible plan. Here's a plan that's similar. It just costs twice as much. His benefit literally went from $500 and something to $1,100 and something a month. And I said, are you getting better coverage? And he said, I'm getting the same coverage, sort of. His kids' doctors are not in the network anymore. They used to, when they had serious things, go to the hospital in Boston because they live near the interstate and it's easy to go down. They can't do that anymore. The local hospital they go to is not in the plan. His doctor's not in the plan. His wife's doctor is not in the plan. His wife's specialist is not in the plan. No one they see now is in the plan. The good news for them, though, is they do have some coverage that they didn't used to have before. So, for example, they have to be provided maternity coverage, which he declined in the past because they're older and are done having kids. But now he has that coverage.
That's nice.
That's nice. And they're all, but he no longer has an option. He can't choose. It's not real insurance.
He has all the conception, what do you call it? You never know.
You just never know what's going to happen. But
oh, great!
So that's a disaster, and so I don't know. So the extent to which we can have more providers with more choices is always a good thing.
Yeah, and how is Medicare being affected by all this?
Well, a lot of people know that as part of the global budget for the healthcare law, Obamacare or the ACA. That one of the things they did is one of the ways they pay for Medicaid expansion, for example, is to make very significant cuts in Medicare. And so, because they want to attract more young people into the system and they don't have the money, so they're going to take the money out of Medicare to provide it. I don't know what's going to happen there because politically those cuts are very difficult. Those cuts are very difficult to push through, but they're in the law. And I imagine some fix will happen because it's very difficult in an election year to cut Medicare. But then if that happens, the law's not balanced and it doesn't work and we can't pay for it. But I think that may become moot because right now, because things are disaster, there's all sorts of discussion about not making people join. And a lot of people aren't joining. But the people who aren't joining are young, healthy people.
Right, that's the ones they need.
Because it doesn't make sense. If you're young and healthy, why do we want you in the plan? Because we're going to charge you an arm and a leg, and we know you're not going to use any insurance. So we take all of your money and transfer it to older and sicker people. Now, as somebody who, as I get older, I see some benefit to that idea. But if that doesn't happen, the insurance company will be providing coverage only to older, sicker people. And the younger, healthier people don't come into the plan. It's like providing fire insurance only for people whose house is made out of gasoline-soaked balsa wood. Not helpful.
I love your examples.
Thank you.
Well, we talked about some of these other ways of doing this. That article that I mentioned to you earlier before we started this interview from Forbes magazine. Now, there seemed to be a straightforward using the system that's currently out there, regular commercial insurance, with a medical savings account and also with a fund for the people who are extremely needy. How does that look in your opinion?
Well, I think you could do something like that. There's no question that the government might have a role to play in things like a high-risk pool.
Yeah, high-risk
where there are people who have difficulty finding insurance because they're at risk, and the government can step in there.
Right.
It's a smallish group of people, and it makes insurance affordable for everybody else if that high-risk group is
handled
separated
that way instead of trying to.
The difficulty is that a lot of sensible things are not eligible for 100% reimbursement from the federal government. And so people will be looking at that. I think, though, something that will happen is that this will be a big issue in January. This will still be a big issue in January. People will be looking for some sort of a deal. I hope that something with an HSA-like component, some sort of a patient-directed account can be included. This is something that's happening in Indiana right now, is happening through Medicaid right now. And I think they call them power accounts in Indiana. But the idea is to involve you in your health as well. And so that rather than all the care management taking place from a benevolent overlord, so to speak, it's that you're part of that process and you're
I think that's you have to have something in the,
I hope so.
Skin in the game, as they say.
Skin in the game is a good thing, and people want to be involved. To the extent that you're involved in your own health is in general a good thing in every aspect of health, not just insurance.
Oh, I know I've been talking to my doctor. They're not happy from their end. They don't like what's happening. They feel they're losing a little bit of control, and they're being told what to do too tightly.
It's difficult. I think it's a one-size-fits-all approach that, in fact, doesn't fit anybody.
That's right.
It's not good for most people and bad for a few. It's actually bad for most people, and that's why
you don't have any choice at all. You really don't have any way, and you got to take responsibility for your own health.
We need people more involved, and we need to sort of break that connection where they just think, "Oh, my job will take care of it, and I don't care what it costs."
That's essentially what you're having now, and the media doesn't do a good job of explaining this. There's a lot of things that you said just tonight that I don't think was ever printed in the newspapers.
Well, it's a very complicated law, and I think that the media and particularly television and newspapers they're afraid of losing the reader, and the reader won't read past the second or third paragraph. But it's probably important that lawmakers know a little bit more than they do.
I think so. Well, thank you, and we're going to have you back sometime in the first quarter after we see what they start with. And,
I'd be happy to come back. Always good to be here.
It'll be interesting, and you don't have to worry about a budget this year anyway.
That's right.
That's what you usually get involved in. But thank you again for your time and your expert advice.
Thank you.
And thank you for listening in. And don't forget, go to the Republican Club website, NashuaGOP.org, to find out more about us and more about our programs, and to look at past programs if you want. Good night.